And welcome to week 10's recorded session. This information for this session is coming from your textbook from Ward, Heisley, and Kennedy, and it is also coming from your Nursing Care of the Child ATI textbook. So let's get started. We're going to be talking pediatric emergencies today. So there are respiratory emergencies, and the one that I'm going to be focusing on is airway obstruction. So this can come from aspiration of a foreign body, such as food and or toys or small parts. Risk factors would be our toddler population. You know, they're very inquisitive. They're trying to learn their world. So they're going to be grabbing things and maybe putting things in their mouth, and it's not always a good thing for them to do. It could also occur because of an anaphylaxis issue. So let's think about bee stings. That's the one that comes to my mind first. Also, peanut allergies. A lot of times we don't realize that there's a peanut allergy until they experience an anaphylactic reaction to the peanut. So all of those things could cause a potential airway obstruction. So the nursing care, obviously, we want to maintain airway patency. If able, we want to remove an observable obstruction. Think about CPR. We want to, if there's something that we can see, we want to try to grab it. Monitoring their respiratory status, administering oxygen as prescribed. We want to make sure that we're using a calm approach for the child and the family, being very calm. It's very important how we look on the outside because they're going to be very anxious and scared. Both the parent and the child are going to be anxious and scared. So we need to be very composed. We need to be very in control of the situation. We want to make sure that we're keeping the family informed. When we're doing things, we want to make sure that we're talking to them while we're doing them, explaining why we're doing the certain things that we are doing and what it's going to do for the child, what you're looking for when you're monitoring them, because you're going to be monitoring them very frequently. So what you're looking for when you are doing all of that monitoring. Submersion injury. This is asphyxiation while the child is submerged in fluid, and it can occur in any kind of standing water that is at least 1 inch deep, so it doesn't take a lot of water. These injuries can occur from the bathtub. They can occur from the toilet. They can obviously occur with swimming pools. They also occur in ponds and or lakes. And one of our highest risk population, again, we're going to go back to the toddler because they are investigating, they're eager to learn their world, they're venturing forth a little more, kind of getting away from their parent or whoever is supervising them. And sometimes they can get into stuff. And sometimes it can be a real issue. It can cause real problems. But children older than 12 months, obviously swimming, right? Swimming without wearing protective gear like inflatable wings, right, for their arms, or a life vest, maybe. Inadequate supervision. And this doesn't mean that the parent or whoever is in charge of the child is kind of falling down on the job, as it were. It doesn't mean that. It just means that these kiddos are pretty quick and they get into stuff very quickly. And, you know, when maybe there's a lot of chaos, maybe they're having a party, let's say, and something occurs, and the next thing you know, you can't find the child. And where is the child? They get away just that quick. You turn your back for a second and they're halfway down the road. So, you know, these kind of situations happen very quickly, but they can also occur intentionally through child abuse. So that is something that, as the nurse working with families, that would be something to be aware of, because part of our role would be to find out that history information. What led to this submersion injury? What was happening? What was the precipitating event? So nursing care, they are going to be in an intensive care environment. They are going to require very intensive monitoring of both cardio and pulmonary status, neuro status. Everything's going to need to be monitored. Obviously, administering oxygen, and the majority of the time, it's going to be through mechanical ventilation. So these children are going to be intubated. They're going to be sedated because they're intubated, right? We're going to be monitoring their vitals, obviously. We're going to be administering different medications. Sometimes we administer paralytics when these types of children are intubated to prevent them from trying to reject the vent. We're going to be giving them IV fluids and other emergency medications as prescribed. Provide chest physiotherapy because we need to get that fluid out because the fluid has been aspirated into the lungs. And so chest physiotherapy is a way that we can get that fluid out. Postural drainage, repositioning them, turning them during the chest physiotherapy. We need to monitor for complications, especially during the first 24 hours after the event. And some of those complications, cerebral edema. So we're definitely on the watch for increased intracranial pressure. Respiratory distress, definitely respiratory distress, because they could get some inflammation to their airway because of the asphyxiation, because of the insult. If it's a anaphylactic type of reaction, they definitely get some type of inflammation and swelling of the airway. Again, we want to make sure that we're keeping the families informed. We want to be educating them and supporting them throughout the entire event. Everything that we do, all the interventions we are doing, all the assessments that we are doing, we want to make sure that we are providing that anticipatory guidance continuously, all of the time. So some complications in the infant population, phenylketonuria, that can be a tongue twister, can't it? This is an inherited metabolic disorder. Newborn lacks the enzyme phenylalanine hydroxylase. This enzyme converts phenylalanine into tyrosine, which is an essential amino acid. It can cause cognitive impairment. So all newborns are screened. This is the PKU that we do before the newborns are discharged home. Some of the nursing care, we're focused on dietary intake. So we want to initiate dietary restrictions within that first week to 10 days after birth. We want to place the newborn on a formula that is low in phenylalanine. We want to provide education and support to the parents. We want to make sure that we are on the lookout for any complications because they could be severe. The cognitive impairment could be severe. These kiddos may have some bizarre behaviors that the parents may see. They may be very hyperactive. They can be inflict self-injury. They can headbang. They can bite their arms. They may be a little bit disoriented. So definitely have to be providing all the education and support we can to the parents of these kiddos. Necrotizing enterocolitis, or NEC as it's called. This is an inflammatory condition of the gastrointestinal tract caused by ischemia or hypoxia. Ischemia that results in death of the mucosal cells, leading to necrotic patches that interfere with digestion. These kiddos get very sick very quick. So when I was working in the special care nursery environment, it was standard practice that we would not feed those kids that got admitted to that environment, whether they were premature or term, didn't matter. We did not feed them for the first 24 hours because of this, because this was such an issue and it can go they can deteriorate so quickly. So some of the risk factors are prematurity, respiratory distress syndrome. Remember, it can occur through hypoxia, shock, and asphyxia. So if there's some sort of birth trauma, maybe the baby gets caught in the birth canal for some reason and they are left hypoxic for a number of minutes or whatever the case may be, that can cause an asphyxia type of insult that can lead to necrotizing enterocolitis. So the nursing care, obviously we have to begin with prevention. So that withholding of feedings that I mentioned a few minutes ago, that is one of the things we do to prevent this event from occurring. Initiate feeding with breast milk because breast milk has a protective effect against the development of neck. It protects the baby's gut. It provides like a protective layer, if you want to think of it that way. Discontinue all feedings at the first sign of this problem because it deteriorates so quickly. And if you continue feeding them, that only compounds the problem. We want to administer IVs. We may even need to administer TPN if necessary because we want to allow bowel rest, right? We will be putting down NGs for decompression. Now, that was another standard practice in the special care nursery where I worked. All the babies that came in had started off with OGs in the mouth, and then they were changed to NGs, and that was standard practice. And that was to avoid this problem. That's how much the neonatologist feared this issue. So we did everything possible to prevent it from occurring. Abdominal girths, because they will get distension. Prepare the family for a possible surgical intervention. It may be necessary for the docs to go in and perform surgery. So we need to be educating. We need to provide that anticipatory guidance. We always want to make sure that, again, we're educating and supporting the family. This is a very traumatic event, and it can have serious consequences, life-threatening consequences in some cases. So this is not something that we want to just leave them to their own devices. We want to make sure that we're providing all the love and care and support that we can, make sure that we're educating them with all of the pertinent information that they need to know, and just providing that very supportive presence. Just being there, letting them know that we are there to support them means everything. Shaken baby. So the other name in your textbook, it's called abusive head trauma. I've taken care of several kiddos, unfortunately, with this problem over my time. Non-accidental injury. This is not an accident. This, in most cases occurs because of an abuse situation. So major rotational forces may be intentional. So, they pretty much grab the baby by the shoulders and they shake them. That's basically what happens. Or they throw them and the baby gets shook. Okay. Most victims are younger than 6 months of age. Usually the father or male acquaintance of the mother is, a large percentage of the time that is the perpetrator of this type of abuse, but the mothers are not excluded. I've taken care of plenty of these babies that the mothers were the ones that perpetrated the problem, the abuse. So they're not exempt. There is a situation with newborns that we educate new parents about routinely called purple crying. And what that is the newborn just cries. And they can cry for hours, sometimes up to 6 hours in one go. They just cry and cry and cry, and there's just nothing you can do to settle them down. And the cause of this is really unknown. They keep studying it, they keep researching it, but we really don't know the cause. Sometimes it's colic, but it's not always that. But the thing we want to educate the parents about is that this is a potential possibility and this can really be frustrating. So if they notice that they're getting frustrated with baby, that they need to put the baby in a safe place in the crib, right? Maybe just put them in their crib and walk out of the room and go into another room and just take 10 really deep breaths to calm yourself down, because this kind of situation happens so quickly, and once it's done, it's done. You can't undo it. And that's part of the education that we provide is we want to prevent this from happening. And if you notice that you're really starting to get to the end of your tether, you really need to make sure that baby is safe and that you walk away to compose yourself. Maybe call somebody, have somebody else come and be with baby so that you can take a little time. Maybe have a friend or family member come to the house so that they can be with baby and you just go get in your car and go somewhere. Some of the complications that can occur: neuromotor impairment, visual impairment. They can actually have tearing of their retina from the force of the shaking. Developmental delays. These kiddos, they start out being perfectly normal and beautiful. I took care of one once. Oh, what a beautiful little baby. But, she did have neurologic impairment after this event. She was still beautiful. That didn't change the fact that she was beautiful. It just changed her. It changed her opportunities in life. Signs and symptoms: seizure, apnea, bulging fontanelle. That's definitely a sign of increased intracranial pressure when you have a baby that has a bulging fontanelle. Coma and bradycardia. Okay. The brainstem can be affected. And once the brainstem can be affected, we're talking respiratory depression and we're also talking bradycardia. Or, yes, bradycardia. Sorry. I'm all right. All right. So, some nursing care, initiation of maintenance for the respiratory and cardiovascular systems. Assess for that increase of intracranial pressure, changes in level of consciousness, bulging of the fontanelles. Health history and event history. Now, this is not a pleasant conversation to have, but it is a necessary conversation. We need to know what happened that led to this. What was the precipitating event that led to this occurring? Child may have long-term impairment requiring ongoing therapy. We need to try to prevent any complications that could occur, like infection or contractures, if it's a neuromuscular insult. Decreased muscle tone. We need to try to prevent, by doing passive range of motion with babies. We're going to have them being seen by physical therapy, occupational therapy, speech and language therapy. Outcome depends on the severity of the insult. How severe is the insult? Okay. And again, providing that education and support to the family. We need to let the family know that this could be a potential legal implications to this problem. The police are probably going to have to they will have to be involved. We're mandatory reporters, so we would definitely have to report something like this. Epiglottitis. Sudden, potentially lethal condition. This is a serious problem. If we notice that this is happening, we got to get on it right away. We got to start doing all those interventions to try to decrease the inflammation. They may have a high fever, definitely complain of sore throat. They're going to be having dyspnea, rapidly progressing respiratory obstruction. This is an inflammation of the epiglottis. So that definitely is going to affect the airway. It's considered a medical emergency. We got to get it solved and quick. They will have drooling. These kiddos have drooling. They have stridor, which is kind of like a croaking sound of the upper airway. Thick and muffled voice. It's going to definitely sound muffled because there's lots of inflammation and swelling happening there, right around the epiglottis. Their throat will be red and inflamed with a distinctive cherry red epiglottis. So, as I said, we have to work fast. We have to get in there quickly. Things have to get done really, really fast. So the nursing care, obviously maintaining the airway is going to be our priority. Providing oxygen as prescribed. Reduce the child's and family's anxiety because, there's nothing worse than not being able to breathe, right? So that's a very scary situation to be in for the child and for the parent. Provide rest. Try to help them to rest as much as possible, conserve their energy. Monitoring fluid balance because they're going to be tachypnic. So, you lose fluids when you're breathing really rapidly. Administer medications as prescribed. So things like corticosteroids to try to reduce the swelling. Very commonly, Decadron is what's given in this situation. The other thing that we did was racemic epi nebulizers. So epinephrine to reduce the swelling as well for this type of problem. Very common. Motor vehicle accidents. Okay, so motor vehicle accidents, traumatic injuries from a vehicle accident. Occurs most frequently with our adolescent population when we're talking about pediatrics, but it can occur at any age level. I mean, the parents can get into an accident, and if it's a really significant car accident, everyone that's in the vehicle can be affected. So that can include children. Some of the complications that could come from a motor vehicle accident are fractures, possible head injury, and potential of hemorrhage, right? Depending on how significant the injury, where the injuries are at. Sometimes these kiddos can get pinned in the vehicle and they have to be extricated from the vehicle by EMS. It's just, it can really be quite a serious issue. So some of the nursing care that we are going to be providing, we obviously want to obtain any health history information. We want to obtain the history of the precipitating event, so what led up to the accident. Obviously, the airway, we got to maintain the airway. We're going to be monitoring their vitals and their neurologic status. We're going to be providing education and support for both the child and the family, and anticipatory guidance because these kiddos may require surgical interventions. They may have long-term, lifelong effects. They may require ongoing care. So it's definitely going to be something that we want to be providing that anticipatory guidance for. Okay, so the last bit I just wanted to focus on for our recording today is a little bit about the intensive care unit. So with all of these different emergent situations, the child may require intensive care monitoring. So a pediatric ICU works very similarly to an adult ICU. There's very intense monitoring. There's times where it can be one-on-one depending on the situation. And it's very overwhelming for the child and for the family because there's constantly somebody poking and prodding at them. They're hooked up to lots of different, very technical looking machinery. It can be very um, intense looking. It can be a little scary because they don't really know what all these different things do. And remember, as the child, they fear pain because they don't know if these things that they're being subjected to are going to be painful for them. There's lots of monitors, there's lots of alarms going off. It sometimes can be a very kind of chaotic environment, and that can be very overwhelming. And they may also feel a little bit of isolation from their family and especially from their friends. If you're dealing with your adolescent population, as we've said before, their peers are everything. And they may feel some isolation from that peer network because that's part of their support system. So obviously, it's going to be very important to provide anticipatory guidance to the family and to the child about this environment that, we're here for them. There's no reason for them to be afraid that we are going to be here. And we're very close. We're going to be with them through the whole process. We're going to explain everything that we're doing and everything that's happening to make sure that they understand. You always want to provide that support and anticipatory guidance in all of these intense, very critical type of situations. It's just key to the whole ball of wax. Well, that's all I got for you guys. I hope everybody has a great day. Thank you.